Thank you for coming out and welcome. Welcome to the 6th Annual UCSF School of Dentistry Global Oral Health Symposium. My name is Benjamin Chaffee. I am the director of our School of Dentistry's program in Global Oral Health, and I'm really delighted to get today's event started. I'm so happy to see people in the room and a lot of energy and anticipation for what I hope is going to be a really exciting program. And now to introduce our next speaker, I'd like to call to the podium Dr. Ling Zan.
Hello, everyone. It's a great honor for me to introduce our next keynote speaker, who is also a long-term alumni of UCSF, Professor Michelle Hensham. She graduated from UCSF in 1993, and then she moved to Boston and received a master's degree in public health from Boston University. And she has been a faculty in Boston University since 1996. Michelle is the Associate Dean for Global and Populational Health at Boston University Henry Goodman School of Dental Medicine. And she manages all the school's extramural rotations and community-based activities. In addition, she also served as the co-director of the Northeast Center for Research to evaluate and eliminate dental disparities. That was established in 2001. It's one of the 4 centers that was funded by NIDCR, like the ones we have here in the Can-Do Center. Michelle's work has promoted the development of the programs and partnerships within the Boston University with diverse national and international organizations, in focusing the goal to reduce global health or disparities. She has also served as an officer in the Community and Prevention Dentistry section of American Dental Educational Association, and also president of Boston sections of the American Association of Dental Research. She's also the past chair of the Massachusetts Coalition of Oral Health. Her presentation today is going to present us the battle of the most prevalent disease in children in the United States and probably worldwide as well, early childhood caries. And since the establishment of the Northeast Center for Evaluating and Elimination Oral Health Disparity in 2001, they have been focusing, developing innovative and effective models to involving, especially in an interdisciplinary fashion, involving non-dental providers and in non-dental settings to combating this disease. And her presentation will be focusing, discussing the history of the NIDCR Oral Health Disparity Centers and the findings of the CREET Center that's in the university and the lessons they learned and resources that were available for combating early childhood caries worldwide and globally. Please join me to welcome Michelle for the presentation.
Thank you. I want to thank Ben and the rest of the organizers for inviting me to participate in this wonderful symposium. I'm really looking forward to sharing the path that we've taken with the NIDCR Disparity Centers and also the work that we've been doing as part of CREED. But I do want to take this opportunity to also acknowledge Dr. Raul Garcia. He is the co-director of the center, the co-PI of our Disparities grant, and has really been the driving force behind much of the work that I'm going to present today. So the bulk of my presentation is going to take you down, as I said, the path that the Disparities Center Research Program has been on, using the Creed Center as an example, starting with the Phase 1 centers, going down the road to Phase 2, and then now we've just taken a fork in the road and left the centers program and entered this multidisciplinary and collaborative research consortium. But before I do that, I wanted to just take a little bit of a step back and talk about the context that the health disparity centers have really grown up within. And I guess it's wonderful when you're a symposium organizer and you see that your speakers are all in alignment. There's going to be a little bit of, not redundancy, we'll call it repetition for emphasis between my presentation and some of the previous ones. This is to show some of the key and diverse organizations and some of the responses they've had to both health disparities in general and global oral health disparities. I'm going to talk about some of them in my presentation, but one of the key messages you'll see has already been highlighted is really integration into these broader goals. One of the fabulous things is the disparity centers have actually been bookmarked between the UN Millennium Development Goals for 2015, right before the Disparity Center started, and just in January of 2016, they released the next set of Sustainable Development Goals. So, my summary and take-home messages in reviewing the various reports and initiatives and calls to action are really, we've sort of heard a lot of this already, especially from Richard earlier, but a lack of focus on societal levels and the social determinants of health. That's really where we need to move forward. Addressing oral health disparities in isolation, we can't do this anymore. And Richard already gave you the two examples that I was going to use, which actually, interestingly, bridge last year's Global Oral Health Symposium and this year's, because these were actually the two topics that we talked about, was sugar and oral cancer. Focus on treatment instead of prevention. The clinical work is wonderful and important, but finding new ways to bring the preventive services to those who need it most. And when we do have those preventive services, they aren't accessed equally by all. They're clearly inequities. And in part of that could be due to the really narrowly defined workforces that we have. We're getting better in dentistry, but still those preventive services can be delivered by many more people than just dentists in the narrowly defined dental team. And the IADR has given us, some of our charge here in terms of the global research priorities. I have 2 slides, and I've only selected about half of them, the ones that really map onto the factors that I've already described. But there really is, I think, consensus out there of where the field needs to be moving. Again, social determinants of health, this importance of integration and collaboration amongst professions, really expanding who is looking at oral health disparities research, really a much more multidisciplinary approach, and developing these upstream community level interventions. And I had to give one little plug in my presentation too, to focusing on the social determinants of health and really weaving into some of these larger level initiatives. And we've already seen a slide here, reckoning back to Richard's talk about the social determinants of health and how important it is. But this slide is mostly for the dental students in the room. So when I was a dental student back here in the early 90s, this is what the field thought. This is what we were taught. It's what dental students all across the country were taught of. This is what caused dental caries, this Venn diagram. If you could eliminate that overlap, you wouldn't have caries. There wasn't really the appreciation of how that Venn diagram, which is very important and is still a nexus in our conceptual models of oral health and oral health disparities, but that there's so many levels of influence on that Venn diagram that if we don't pay attention to those levels, we're really missing an opportunity for intervention. And so this really highlights the need for an integrated, multi-level interventions, really at all levels. The policy level is key. Again, looking at tobacco and the success that we've had there, and hopefully the success that we will have in sugar. That's here in the United States. Now, those successes have not been shared globally in some of the developing low-resource countries. Changing healthcare systems, communities, and still we do need interventions on the individual level, but we can't just focus there. And the NIH really as a whole was evolving in their understanding and focus on health disparities overall. And you can see this 2010 quote by Francis Collins really calling for this integrative approach and a new focus on health disparities research. And this was really mirrored in the NIDCR and their strategic plan, both in the 2009 strategic plan, which had as one of its primary goals the elimination of oral health disparities. And then in the next iteration of the plan that goes through 2019, a little bit of a rewording of the goal, but really the same focus. And the cornerstone of the NIDCR's efforts to really fulfill that strategic goal has been the Centers for Research to Reduce Disparities in Oral Health, their Oral Health Disparity Centers program, which we call it. They were established in 2001. They were U54 centers. For those of you in the audience who maybe aren't familiar with that mechanism, it means that it's a center grant, but it's a cooperative agreement. So the NIDCR was a true partner in the execution of the centers. They were part of our, bi-monthly meetings of the center. They really were an active participant in everything that we did. In the first round of centers, they were really organized around cores. They had some really, I think, exciting cores. One of them was community engagement. We heard the importance of that earlier. And then one that was near and dear to my heart, which was training core. So really trying to bring young researchers into the field of oral health disparities research, but then also to bring people from other disciplines into working in oral health disparities. So a two-pronged approach. And each center had to perform 4 sort of R01 level activities. And there were 5 centers who were actually funded in the first round. 4 of them focused on early childhood caries, and one of them, NYU, actually focused on oral cancer. In this round of centers, we were separately funded centers. We collaborated, we met sort of yearly, but we didn't really work together in any meaningful or at least structured way. CREED's themes have already been alluded to in my introduction. We really think that translational research is an important part, and not just the translation from the bench to the chair or the bench to the bed, but also taking what we know that works clinically and translating it into community-based settings. And to do that in a way that's most efficient and effective. So trying to find the best non-dental settings where we can meet the most at-risk populations, and also using the most appropriate person to deliver those interventions that can do it in a very cost-effective way. So, one of our examples is we've trained public housing residents to deliver ECC counseling using motivational interviewing in their homes. You can see these are the 4 projects, the 4 R01 level projects that were part of our first center. For these round of centers, you could have a wide range of types of research. It could be observational research, it could have been interventional research, some methodological research. It was really wide open, and we had sort of all different types. Now, I don't have time today to give you a full accounting of all of our outcomes, so what I've decided to do is to really focus on the few themes that have sort of carried out through all phases of the center and how we've built on those outcomes. For those of you who are interested to find out more about specific projects, I can talk to you after, or you can go on the CREE website. There's a slide later that has our link. So one of the first center projects was led by Nancy Cresson, and it was taking patient-centered counseling and introducing it into the pediatric well-child visit, but in a tertiary care teaching hospital. And that worked exceptionally well. We changed the electronic medical record. Counseling behaviors by the pediatricians themselves increased significantly, as you can see here. And more importantly, that actually translated into a decrease in ECC prevalence. The other project was development of a new instrument, a new pediatric oral health quality of life instrument, which we called POQUAL. This initiative was actually led by Dr. Judy Jones. And what was sort of lacking out in the field and why we felt it was important to create a different type of instrument is that typically the oral health quality of life instruments measure how often something happens. It's a frequency measure. But we all know that something can happen many times, and it's really of very little impact on our life. But you can have something that happens just once or twice, and it can have a major impact. So this new quality of life measure, well, it's not new anymore, it was new 10 years ago, actually measures both of those domains. So both frequency and how bothered you are by it, or how bothered the family unit was by this occurrence. So then in 2008 was the next round of centers. These were U54 again centers, so again collaborative agreements with the NIDCR. There were no cores this time, and the type of research was different. We moved from R01 type projects to U01 projects, meaning that we had to have randomized clinical trials. Each of the centers proposed 2 randomized clinical trials, and there was a need to have a hard clinical outcome in the end. So gone were the observational research that was allowed in the first round of centers. So again, there were 5 centers that were funded. Again, one focused on oral cancer. That was, this time it was the University of Florida. And then the other 4 focused again on early childhood caries. Now, I can't talk about phase 2 of CREED without talking about the EC4, the early childhood caries collaborating centers. 3 of those 4 centers that were funded to focus on early childhood caries actually had very similar outcomes. They had some similar research methodologies. And so the NIDCR asked us to come together and form this collaborative and really work together to develop some commonalities, which I'll talk about in a minute. You can see the 3 centers here, and the 4th is actually the addition that makes up the 4th is the Data Coordinating Center, which is also located here at UCSF. So we have the CANDU Center here. We have the BU CREED Center, which I'm talking about now. And we have the University of Colorado, Denver, or the CNOR Center. And so, what were the benefits of bringing these organizations together? Well, it really allowed a leveraging of resources and an efficiency. You can see that in sort of the first 3 bullets. We shared common DSMBs, common monitors, but I think the real importance was the work that we've been able to do in terms of working together to develop common measures and methodologies that can really move the field forward in terms of oral health disparities research. And so some of these products and resources are available to you all through the website that's listed here. And you can see just a sample of what's out there. Developed here at UCSF is the web-based Caries assessment tool, otherwise known as Karen. A clinical examiner training, which is a little bit atypical, but really an important addition to the literature, because a lot of the work that we do in oral health disparities research is out in communities and out in the field. So doing calibration in clinical setting in a dental office where you have air and water doesn't really work for us. So the methodologies need to be changed and adapted to be used in field settings. Clinical trials management system adapted for behavioral interventions. Probably the most commonly used item to date is the Basic Research Factors Questionnaire. So this is a very lengthy questionnaire which covers every domain I think that you can think of related to early childhood caries risk, demographics, knowledge, attitudes, beliefs, and that has been used now in many studies across the United States. And it will allow us to compare different population groups with data that was collected with common methodology. Another resource that is out there is our recruitment paper. It is very challenging to recruit underserved minorities into research. And we all have the scars of doing that. But we were all very successful. And there is a paper you have the citation here, just putting a little plug for that, that shares some of the lessons learned, not just the things that were successful, but the things that we tried that didn't work so well, so that researchers going forward can really learn from our successes and our mistakes. And very shortly, there will be a companion paper that will hopefully be published. We're working on it now, which as our studies are coming to an end, will really highlight the strategies that we found most successful in retaining those subjects. Each of the studies followed these populations for 2 to 3 years, and we were able to all maintain retention rates at the end of the study in sort of the mid 80%, which is really phenomenal in these population groups. So we're hoping that that will be another very important contribution to the literature. So I'm going to go over just very briefly the 3 centers that are part of the EC4 and the Data Coordinating Center. I'm actually not going to talk about the Can-Do Center piece because Dr. Gansky is going to come up after me and do that, but I couldn't not have their slides here because they're such an integral part of the EC4. So we're just going to skip over those. More to come. In the University of Colorado, Denver, the CNOR Center, its mission is really working with American Indian populations. They have 2 randomized controlled trials. Both of them have as their primary outcome DMFS levels. And you can see the 2 trials here. One is, again, very much like one of ours, focused on motivational interviewing in individuals' homes on reservations. The other is a novel, unique sort of dental care delivery service done in Head Starts that target American Indian populations. So they applied fluoride varnish, provide oral health education within the classrooms, have other classroom activities, and doing this using a community outreach worker, which they call a community oral health specialist. And then the Creed Center, as you see here, we also had 2 studies focusing on, first, partnering with community health centers to prevent early childhood caries. So this really took the work that I described earlier that Nancy Cresson did as sort of our foundation of training these pediatric providers in tertiary care teaching hospitals, and to see if we could take that model and move it into a community health center setting, which is a very different environment. The focus really there is on patient care much more than education. And then the second project, Oral Health Advocates in Public Housing, is my project along with Dr. Belinda Borelli. And that is the one that focused on training public housing residents on ECC risk factors, how to prevent ECC, and then how to really develop motivational interviewing skills that they could deliver with great fidelity. It took months to train our community outreach workers, we call them oral health advocates, to be able to really deliver the MI. It took almost 3 months of training, sometimes a little more. But we felt it was really important to be able to train peers from the community to deliver this. This is what we heard that the community wanted. They didn't want to have, someone come in from the outside and start telling them about how to take care of their children. They really felt that they needed to have that message come from one of their own. So what we learned from CREED 2, and I need to say that we don't have specific results yet. These were, the OHAP one was a clinical trial. We haven't finished collecting the data. We've collected about 90% of the data. We should be done by October, but because it's a clinical trial, obviously the data is all embargoed, so we don't have any preliminary results. But we do have some sort of lessons learned. And in the community health center trial, we learned that, yes, we were able to integrate oral health within a community health center setting, but it wasn't as easy as it was in the teaching hospitals. It was harder, not surprisingly. There were more barriers. Time pressure was much more of an issue. So we could do it, but the sustainability was a little bit of a challenge. We were able to develop ECC counseling messages. So this isn't education. This is counseling, which is different. It's setting goals. It's identifying barriers, thinking about how you're going to overcome those barriers. So really a strategy for people to move forward with making behavioral change. And we were able to take that information and tailor it to two different communities: community health center participants or patients, and then our public housing residents. And we were able to successfully train lay providers, all of whom have just a high school level education, to deliver MI and to deliver it with fidelity. And there was a lot of concern that this wouldn't be possible. It hadn't been done in any other field, not only in dentistry, but in medicine across the board, that have shown that you can do this. There was a lot of skepticism that we would be successful, but we were able to do it, and we strictly monitor our OHAs in the field, and every session is taped. We listen to 20% of all of the sessions to make sure that they're delivering the intervention with fidelity, and they're keeping true to the principles of motivational interviewing. But what we did learn in the public housing trial is that it's, even when you take the counseling out of the clinic session and take it into people's homes, it still was a burden for participants to engage in a full 30-minute MI session in their households. And that was a significant barrier, but we also learned that our participants really love to communicate electronically. They love to text and email us. They didn't want to, it's like my 16-year-old daughter. She doesn't ever want to talk to me on the phone. She just wants to text me. Well, our participants were exactly the same way. Meeting us in person was a challenge. Talking to us on the phone was a challenge. But if we would text them or email them, we would get a response. And so where we are today, the UH2, UH3, and I'll talk a little bit about that in a minute, what that sort of means. Building on what we learned from CREED 1 and CREED 2 is we now have these two new projects that are part of this consortium. I'm not going to read the name of our first project because Dr. Burley and I failed in learning how to name things concisely, but you can read it up there. This is also a great example of what happens in partnerships. So we had 10 people who were trying to name the project, and everyone had their pet word that needed to be part of the name. So this is what happens by committee sometimes. But it is very descriptive of the project, we will say that. And the second one is using social networks to improve oral health, which is headed by Dr. Garcia. And these projects are both part of that fork in the road that I talked about, the centers going down. So there is no more center program. The NIDCR stopped funding the oral health disparities centers, and instead their new oral health disparities initiative is the multidisciplinary and collaborative research consortium to reduce oral health disparities in children. And I'm going to talk a little bit about them, but you can also go online with this link and read more. So there are actually now 9 studies which are funded to focus on the oral health of U.S. children. So no longer is there oral cancer. All of these studies are focused on children and children's oral health. There is one data coordinating center again, and that is still remains here at UCSF. And the initiative really carries forth, I think, one thing from the previous rounds is dedication to community engagement and making sure that the disparities research that we do as researchers is informed by our communities. But also thinking back to, the Fisher-Owens conceptual model of oral health or the social determinants of health. One of the requirements this time for these consortium applications were that any interventions proposed or any project proposed had to have multiple levels of intervention within it. You couldn't just focus on the individual level or the policy level. You had to focus on multiple levels. And so you can see here the 7 universities which represent the 9 studies. So it's a different group, a little bit more geographically dispersed throughout the US. And the theme that sort of unites the UH2, UH3 projects that BU is doing and hopefully continuing the work of the Creed Center is really the use of technology and mHealth, which really ties to the UN's new Sustainable Development Goals. 2 of the goals have targets that really focus on expansion of technology and trying to facilitate and expedite science and technology transfer to low-resource communities. But the global expansion of technology is really astounding when you look at the numbers. So for cell phone subscriptions, now the number of cell phone subscriptions is almost equal to the global population. I think that's a staggering statistic. Now, that certainly doesn't mean that every person has a cell phone. We all know someone that has 2 or 3 cell phones. But we're getting there, right? We're getting really close. The permeation is staggering. Not so much with the internet, but we're getting there. About 50% of the global population are now internet users. And this has huge implications for how we can think about interventions in the future and how we can develop partnerships to disseminate our work. And so these are some of the opportunities that we think are available and that we're trying to build upon. So the text messaging program, which I'll talk more about in a minute, really an interactive tool to provide tailored prevention or behavioral interventions. So taking people's risk factors into account and providing a tailored intervention for them based on the information that they've provided. Using electronic health records to integrate risk assessment, and to increase efficiency into screenings. Using GIS for mapping and to really understanding the epidemiology of disease and doing overlay maps, example of tobacco use. Remote diagnosis, and I'll share a quick example of that. And then, even more importantly, I think, starting to think about more strategically communication between healthcare providers in low-income, low-resource communities and high-resource groups. So I'll tell you a little bit about our projects. So the first is using social networks to improve oral health. I have a disclaimer here. I am not an expert in social networks. I know just enough to be dangerous, maybe not even quite that much. So this is not my project. But social networks really refer to the network that people have that information can be exchanged through. So, and you can actually map those networks. And social network analysis is actually, a research strategy that you can use to map those networks. And what you can do then, once those networks are mapped, and you can see that there's 2 different approaches. We've been using the egocentric approach to identify individuals in a system and then really map their network. And you can imagine that the way that those network maps look now is very, very different than the maps 20 years ago, right? Our focus is mapping a couple of public housing developments, which you would think would be relatively contained communities, and to really see how information flows and how people interact within those communities. But now, with cell phones and internet, those networks look very, very different than they would have decades ago. And that really is a potential for us to be able to use technology to influence very large networks across populations and across wide geographic distances. And so the UH3, the central hypothesis, is actually taking information, trying to diffuse it through those networks in a way to sort of like to use the opinion leaders or the champions within those networks to try to diffuse information in a way that will help facilitate uptake of behavior change and adoption of positive behaviors. And we've not used this in the area of oral health, but it has been used in other areas and been used successfully. So then our project, the very long named one, which we lovingly call the Oral Health Text Messaging Project. And so our target population is not public housing this time. Our target population is building on the community health center model. So we're looking at very young children, ages 1 to 5, and whose parents are seeking care for them during a pediatric visit. And then that multi-level intervention part is really interacting with the pediatricians and the healthcare delivery system within those health centers to make sure that oral health is truly integrated into their system. We've talked a lot about that. There's a lot of focus on that in this country, but there have been really varying levels of success in integrating within the pediatric child visit. But what we feel is that any additional behavioral intervention that we try, we want to have done against the backdrop of an ideal systems level to see what the incremental value is. And why do we choose the community health centers? I alluded to this earlier, that really that's where most of the vulnerable children in the U.S. are seeking care. About 4.5 million underserved underrepresented minority children receiving their pediatric care at community health centers. And so why text messaging? We had the sneak peek of when we looked at things globally, but when we look here at the US, we don't see much difference. The uptake of text messaging is really pervasive. 90% of U.S. adults regularly use a cell phone. And interestingly, if you actually look at texting patterns, it's the same populations that are at highest risk for caries that are texting more. So it actually aligns very well with what we're trying to do. And what are the benefits of texting? Well, one of I'll let you read some of them. I'm just going to highlight a couple. One of them is the scalability. Once you have the system designed and that you have it tailored for the specific population you're working for, it doesn't take much extra resources to expand it. The ability to target. So our participants will be, filling out their forms, will really integrate that information about their risk factors into their profile. And then when their behavioral messages are being generated, they're going to be based and tailored on the information that was provided by the participant. We can get feedback from them. So as we're texting them, there's going to be polls. It's going to be a really interactive system. So we'll be able to collect some more additional information from them on the fly. So, if your Johnny turned 1, yesterday, have you made his first dental appointment yet? Yes or no? No. Why not? Would you like to have a list of dentists in the area who are accepting, year 1 dental visits? Yes. Okay, we can send them that information. So really trying to overcome some of the barriers that we can anticipate. And we're spending a lot of time in the first year doing focus groups with our community to really understand what the barriers are and what these messages need to be. We have some that that we've developed as part of CREED 2, but we really want to make sure that we tailor them based for this, so they're effective for this community. So our primary aim for the UH3, which would be the intervention part once we get through the formative development of the focus groups and developing the platform, is to really test the efficacy of this oral health texting messaging program. So people will be randomized, and they'll either receive texts that are based from oral health messages, or they'll get general child wellness things about, safety. So everyone's going to get text messages. They're going to get the same number of texts. The only difference in the intervention is going to be the content of the messages. And actually, part of the reason that the community health centers are really excited about partnering with us is that, sort of our control arm is actually generating some interesting data for them about general child wellness within their population that then they can use for future research initiatives. They'll have great pilot data. And then I'm going to end with an example from one of my colleagues, which is using technology to try and link, sort of BU here with a more low-resource country in India. So using an app on a mobile phone to try and increase oral cancer screenings out in remote areas of India. And so how this works is she's been using either dental students or general practitioners who are in the area. They've been given this app. They go out in the field, they collect data, they take photos, they enter all the information into the system. The information gets uploaded and gets reviewed by a specialist remotely. And that helps to direct the patient on where to go. There's a lag time, and that's a challenge. It's not an immediate response to the system, but it really has made a difference in the field with expanding the range and ability for oral cancer screenings in really rural areas where there are no health professionals, especially oral medicine specialists. And this is just at its, sort of beginning phases, but, this has the opportunity to do a lot of different things. If you can develop, really sophisticated algorithms, is it possible that you can, some of this can be done, some of the information can be collected by non-dental professionals? Can we use saliva screenings and be, spot testing in the field that would help the diagnosis? I think there's a lot of ways that this can go. This is just one example. We've talked this morning about the importance of using telemedicine in a virtual dental home and what's been happening here in California. So really using technology as a way to link people in remote areas where there are no resources to sort of areas where you have a plethora of resources, and to share those resources across distances, sorry. And so leaving today, just thinking about, where we can use technology to move the oral health disparities agenda forward. So really expanding existing technologies, developing new technologies to facilitate information exchange. Building research capacity and improving clinical practices like the virtual dental home, like the Oncogrid program potentially, especially as a way to expand interprofessional collaborative practice. That's a sort of an untapped resource, I think. And how we can use some of this to actually build capacity within those low resource settings. So it doesn't necessarily just need to be you're always sending data to the specialist who's off site. Can we use some of this information and technologies to start to train those individuals in the lower resource communities to be able to do some of this themselves? Conducting multidisciplinary oral health research and disseminating our findings across nations. Developing and tailoring existing interventions to improve oral health so they're feasible, relevant, and culturally appropriate. We can't just necessarily take what we have developed here in Boston or here in San Francisco and plunk it down and expect it to work in other settings. We really need to spend the time to tailor it, work with our communities, understand how we need to change things so that they're appropriate and will be accepted and be effective. And then one of the challenges that I think one of the individuals in the audience raised, I find it sometimes really challenging to get funding to do these collaborations across countries. A lot of the dollars, especially for oral health research, are funded, by governments. Here, the NIH, in other countries, and they want tax dollars or government dollars to really stay within their country, and that's understandable. So trying to get dollars that will bridge projects across countries can be a challenge. So I saw Ben move, so that was perfect timing. So thank you.
All right, thank you.
I'm Shell, and thank you so much for the great presentation. I just had a couple questions about the POQUAL. I'm an orthodontist here and work with the COHEAP in Latin America. And I just was wondering if you had any, well, 3 questions, but first one, do you have any validated Spanish translations at this point? I know that was an initial desire of yours.
Yes.
Great, awesome. And is the age range to 12?
There are actually different versions of it that go through adolescence.
Okay. And do you have any existing malocclusion orthodontics partnerships looking into kind of the oral health-related quality of life?
One of our ortho residents just did that. Her name is Martha Neely, but it was one small project, and so next steps we'd be happy to talk to you about.
Awesome. Thanks.
Okay, so we'll hear more from all of our speakers during the panel. But to introduce our final speaker of the afternoon, I'd like to introduce one of our graduating dental students, Oscar Reyna Blanco.
All right, our next speaker is Dr. Stuart Gansky, a native of the East Coast who has been with UCSF School of Dentistry since 1996, after he earned his doctorate in biostatistics from the University of North Carolina at Chapel Hill. Currently a professor of the Division of Oral Epidemiology and Dental Public Health, Dr. Gansky, in addition, has mentored numerous trainees and junior faculties, and in 2015 was awarded the UCSF campus-wide Academic Senate Distinction and Mentoring Awards. We are pleased to have him today present on global health focuses on communities, disorders, risk, and prevention approaches and treatments common throughout world without regard of international borders. Please help me welcome Dr. Stuart Gansky.
Thank you. Good afternoon, everyone. It's a real pleasure to be here today. I'm honored and humbled to be sharing the agenda with the speakers that we've had so far, and hope to build on the topics, the ground foundations that they have laid with some examples of our center. And so I'm going to be speaking about global oral health in California. California known as the Golden State, and apparently the current statistics are if California was its own country, it would be the 7th largest gross domestic product. If you care about those things, I don't know about the happiness quotient, but gross domestic product would place it just after the UK and France, and before Italy and Brazil. So a lot going on here in California, as Dr. Pollack mentioned this morning, in a study that he did about 20 years ago, right here in San Francisco and in the state of California. Hundreds of languages, people coming from lots of different places, so we definitely have our share of global health. I want to acknowledge the associate directors of our research center, Drs. Judith Barker and Lisa Chung, who have assisted me with this. If there are any errors or mistakes, they are mine alone. And I want to acknowledge the support that we've had from NIH and NIDCR over this decade and a half for this work, as Michelle mentioned with the Boston University Center as well. And this is with Creative Commons licensing. So we've heard already a lot about the international, national data about oral health disparities We also have California data, which I'll show a little bit of, local San Francisco data, which I won't, and basically want to turn this higher prevalence of caries, blown out mouths, to healthy dentition for children so that they have good starts in life and that they're able to achieve and be successful as adults. Our mission, as is CREED's, is to reduce oral health disparities in children and caregivers through research, training, dissemination with community partners. And our focus is on early childhood caries. So our work has concentrated in California to date, starting in the Bay Area and branching out, working from San Francisco and the East Bay over to when one of our investigators moved down to San Diego County, when there were opportunities to expand and collaborate with others, such as at UC Davis and UC Merced, we were able to take advantage of those and collaborate and increase our opportunities. And most recently, in the last phase, up above our border to Oregon, as I'll talk about a little bit. As Dr. Henshaw showed, the Fisher-Owens model has taken the Keyes Venn diagram and expanded it to the multiple levels of influence. We changed our initial logo for our center to one that is a stylized version of that, so that we're always reminded of trying to think about things in their multiple levels of influence. And so I will use that as the motif for describing the projects and the evolution of our center over time. And so in Can Do 1, as Dr. Henshaw talked about, it was part of the first phase of studies. Our initial center director was Dr. Jane Weintraub, who was the PI of 2 projects, 2 clinical trials, and one of them was along with Dr. Francisco Ramos Gomez. We had a measurement and evaluation core, as well as a qualitative research project and a risk assessment project. And in addition, we had 11 pilot projects during that period. This first phase of the center was for 7 years of funding, and during that that entire 7-year period, there were plans to have pilots, to have additional kinds of projects coming on board as some projects finished their work and sunsetted. So our work is global, not just in the populations that we have, but in the influences that we are part of the global community, and we are influenced by the global community. And so in Nordic countries, it had already been shown that fluoride varnish on permanent teeth was helping to prevent caries in children. But there was a dearth of information about the primary dentition, and so that is what the focus was of one of our clinical trials. The main findings of that study were published in 2006 in Journal of Dental Research, and where we found in 2 clinics here in the city and county of San Francisco that counseling alone versus counseling plus fluoride varnish once a year, that fluoride varnish decreased the caries incidence in these children, and that fluoride varnish twice a year decreased the incidence even more. And so this work and this paper went on to influence some policy and had a very large impact. As these projects began to sunset, we had a second phase of the first round of centers, which I'm calling Can Do 1B. And we had additional projects where Dr. Weintraub was able to go out to partner with folks at UC Davis and join their ongoing study of agricultural workers in the Central Valley in California, where they had large immigrant populations. They were focusing on agricultural worker health, focusing on pesticide exposure and other kinds of health issues, particularly environmental health. But the participants themselves said what they really lacked was adequate dental care. They complained about dental problems, dental conditions, and dental disease. And so They reached out to Can Do, and we were able to participate with them on that project. We also expanded into trying to look at some gene expression in one study, and another qualitative research study which took place in both Salinas, California, and in San Jose, and a study of talking to parents and finding out what their preferences were about different kinds of treatments and modalities, because we could come up with things that work in an ideal world, but if people are not going to use them, it's not going to change the disease state at all. And so this is part of the translational research that Dr. Henshaw was talking about earlier, and harkens back a little bit to what Dr. Watt was talking about as well, of trying to find interventions with the communities. In addition, we had affiliated projects which had separate funding mechanisms, and some of them grew out of the initial pilot projects that we had. And so that robust program then evolved into Can Do 2, which, as Dr. Henshaw described, was part of the EC4, part of the Early Childhood Caries Collaborating Centers with University of Colorado Denver and Boston University as well. So in the Can Do 2 phase, we had a data coordinating center, which was different than the measurement and evaluation core in that it served the other two institutions, the other two centers as well. This was not what the RFA announcement was pitched as, and so it was sort of changed at the time of funding. Do you want funding? Well, if you do, then you need to work together. And looking back on it now, I think that this arranged marriage or shotgun wedding, or as one of my unnamed collaborators calls it, the shotgun menage a trois, actually worked out far better than I ever imagined that it would, because we really did work together and come together on the products that Dr. Henshaw showed initially. But our two main projects, as Dr. Henshaw pointed out, we had to have two randomized controlled trials, and so one of them was the glass ionomer and fluoride varnish trial, headed by Dr. Ramos Gomez, now at UCLA. And I will go into more details about these projects one by one. So first, as I started to say, the Data Coordinating Center, which was previously I was the director of. Now Stephen Gregorich is our current director and is doing a fantastic job. He's in the School of Medicine here at UCSF, and so this also was part of our transdisciplinary and umbrella of bringing in people from other disciplines to help us with wrestle with these topics and these problems. So this is a photo from the very first training and calibration session down in the Native American Health Center in the Mission District of San Francisco. And one of the things you can probably see is there's an awful lot of people with gowns standing around. Somewhere inside there, somewhere in here, is the one child being examined by our gold standard examiner. And so it's not violating any HIPAA rules, because the only people who are pictured are the study team members. We quickly found out that this kind of arrangement isn't very conducive to examining 2-3-year-old children. It's way too scary and too many people. But during this process, we were able to develop the training manual and come up with the calibration and the recalibration. And as Dr. Henshaw said, we recently published a paper which shows the calibration, the reliability, and kappa values for overall. If we disregard the incipient enamel-only non-cavitated D1, IC-1-2, whatever you want to call them, lesions, and consider them sound. And so those numbers are much better, much higher. They were all better than the criterion. But then we also did want to look at these white spot lesions or incipient lesions. And And basically, we have found, as many other studies have, that the kappa values are not very good. At best, they're just sort of barely north of 0.5, which is a bit like flipping a coin. So some of us have argued that in the realm of health inequalities, health inequities, health disparities, whatever word you want to use, even though clinically for an individual, the incipient lesion is important and we want to find it early on, when we're looking at population health, we are interested in things we can measure well, and we're more interested in gross disease and more widespread disease and preventing it. So that was one of the things that the Data Coordinating Center did. Oops. And the glass ionomer and fluoride varnish trial, as I said, headed by Dr. Ramos Gomez, is comparing fluoride varnish alone versus fluoride varnish plus glass ionomer sealants on primary dentition. This study enrolled almost 600 children and their parent over this period of time. This blue curve is showing enrollment over time up to the target level. And then each subsequent curve is showing the follow-up visits, the 6-month follow-up visits, and the final level of retention that we attained. And so the biggest drop-off was between baseline and 6 months, which is not very surprising. Slightly smaller drop-off, and then virtually no drop-off after that. And so we just finished this in February, and we're in the process of analyzing the data to look at our main outcomes. But I wanted to share this with you, and so our overall retention of participants was almost 85%, and this is well above the 68% goal that we had as a target, and even much better than 50%, which is what we had achieved in many of our previous studies. And so it was the central external scientific advisory committee that really held all of the studies' feet to the fire to ensure that we had very good retention. And so I have to thank our staff for their tireless energy, efforts, creativity to have this done, and also note that they did this in a way that was working within the culture of understanding the Latino culture. And this study was performed in San Diego County in 2 community health centers, using personalismo and respeto and all of the things that people have written about that are important for that community to engage them in research. Next, I want to talk about a developmental project that we had, which was the Centering Pregnancy Oral Health Promotion Extension, headed by Dr. Lisa Chung. And this was an extension of the project that was an R21 NIH-funded project, Centering Pregnancy Oral Health Promotion, headed by Dr. Sally Adams. And Lisa's project was to look at longer range outcomes. And so this is working within the existing Centering Pregnancy prenatal care, group prenatal care setting in community health centers, where women come together in a group and share information, share their experiences, and receive information from healthcare professionals in a group, but at the same time forming this supportive network of people who are going through the same thing, all of them being pregnant at the same time. And so they're busy working on papers and getting their information disseminated, but in the meantime, I thought I would show you some of the 2 of the summaries of the modules that they have. So they have 2 modules that were put into Centering Pregnancy. One of them focuses on the oral health of the pregnant mom, including oral hygiene and healthy eating and healthy behaviors. And the other focuses on the health of their baby, their child, focusing on the infectious nature of the disease of caries, which was news to many of them, as well as specific things that they can and should do to take care of their children's teeth. And so look for papers coming out on some of their results. Next, I wanted to talk about our other main study from the second round, which is our fluoride varnish REACH trial, which was headed by Margaret Walsh. Dr. Peggy Walsh had made a huge strides in tobacco cessation, tobacco initiation prevention research, working with communities. And so she agreed to be part of our center to change the research that she was doing and work with children's oral health. Unfortunately and very sadly, Peggy passed away in January, and so we're grateful for the work that she was able to do with our team. She did manage to work with communities. She and her team did extensive trainings with people from 52 clinics and about 250 care providers who wanted to learn how to apply fluoride varnish at well-child visits, but through their own efforts, just looking at information, pamphlets, videos, they had 0% of their medical healthcare providers giving well-child visits, fluoride varnish at well-child visits. Through the efforts, the hands-on, skills-based training, they were able to increase this to 77%, and then a year later, 95%, and then 2 years later, have it be sustained at 97%. And so this information about this partnership and these hands-on skill-based trainings was just published in Pediatrics this year. Another project that we had, which was a developmental project, again, coming from looking around the globe and what works in the communities and the kinds of people who live in California, was a salt fluoridation feasibility trial, which Dr. Barker headed up. And salt fluoride was started, or has been successfully used in Switzerland, was started in Switzerland more than 50 years ago. It's used throughout Europe. It's used throughout Latin America. I think that Dr. Mejia's father was instrumental in having it get implemented in Colombia. And actually, Dr. Mejia helped write this part of the grant application when she was here at UCSF, this Dr. Mejia. So we looked at applying this potentially in the Central Valley in California, very rural, agricultural, where they don't. It's not cost effective to use water fluoridation, and even if it was, many people don't drink water out of the taps. Instead, they get their water from these kinds of things, bottled water from these water mills. And so this paper has just come out recently with the first of many to be submitted or that are in the process. This was published in the journal Appetite. And it actually focuses more on the salt portion of things that a lot of parents didn't understand some of the major sources of sodium in their children's diets. That despite trends of increased sodium levels among adults, among children, and among Mexican Americans, they didn't see their kids as potentially being at risk for hypertension and other sodium-related illnesses. And then they also sometimes, in general, preferred to give their kids salty snacks versus sweet ones due to associations of the sweet ones with diabetes and caries. But then there was some discrepancy during the individual qualitative interviews with someone preferring sweets, someone preferring salty snacks. But clearly there's more work to be done in this area, and look for some of the publications that are going to be coming out and focusing more on the fluoride aspect of fluoridated salt rather than the salt aspect of fluoridated salt. But I just want to point that out, and that it's not an easy issue to wrestle with. And then one of our other developmental projects was a mediation modeling project that Dr. Jing Cheng headed up to develop new methodologies, statistical ways of testing. For Dean Featherstone's Canberra trial, we showed a very strong relationship difference between the intervention and control groups when it came to caries risk over time, but not such a strong relationship when it came to the dental outcome. What Dr. Cheng was able to do is she was able to develop new methodology and use that new methodology to tease out direct and indirect effects, and she was able to find that the camera intervention through the mediator of caries risk reduction impacted indirectly the dental outcomes significantly, whereas the direct effect was not significant. And this was published in JDR last year. This next busy slide shows some of the new research topics, projects, and junior faculty who have been part of our team and part of CAN-DO. And some of whom, including Dr. Chaffee and others who are here, Dr. Mertz in the back, who will be in charge of the panel, and Dr. Chung, have gotten some intramural funding from UCSF, gone through the different phases, and in Dr. Mertz's case, PI of one of our new UH2, UH3 studies, which I will talk about. And so we saw this, as Dr. Henshaw said, one of the education and training missions of at least one center, the previous version of a center, we took very seriously, and mentoring and putting, and I want to thank both Dean Featherstone and past department chairs for investing in this kind of career development, because it takes time and energy and resources. And not every place is patient enough to see the rewards come out, but we're seeing some rewards now. Next, I wanted to show two results from two papers from some of those junior folks. One of them is Dr. Ann Lazar, who reanalyzed our fluoride varnish clinical trial data. And she developed some new statistical methodologies which are applicable to precision health. And what she found is she was trying to identify groups of people for whom fluoride varnish, the fluoride varnish intervention, would work best in. And what she found was that fluoride varnish worked overall, which is what we've had found previously. But she also found that it worked best in the kids who had the highest levels of strep mutans, the highest bacterial levels. And so fluoride varnish for preventing caries incidence worked best in the kids with the highest levels of bacteria. So here are the higher levels, and here the odds ratio is getting smaller and smaller, meaning they have less and less chance of getting caries. And that paper was published in 2013. And then Dr. Chaffee published a paper in Journal of Dental Research, which used our Maya trial data and looked at the relationship between the mother's salivary mutans bacterial levels and kids who developed caries at 36 months versus those who didn't, showing that there was a significant difference with much higher levels of the mother's bacteria in the kids who had caries at 3 years of age. Okay, so because our title of the symposium involves measurement, I did want to talk a little bit about measurement. It's important when we're talking about international comparisons or state comparisons or county comparisons to be talking about things in the same way, using the same metrics. And so the U.S. National Center for Health Statistics issued a monograph that made 11 guidelines about measuring and reporting health disparities. And so I would refer people to that monograph. And then I will say, today is the home opener for the San Francisco Giants. It's an even year, so we're hoping for good things. But I also saw that Sir Michael Marmot tweeted this last week from a presentation he was attending in Canada from Ketan Shankrajas in Ottawa. And so I thought this was a good way to explain some of the concepts or use an analogy. So equality is when everybody has the same size stool, even though you still might not be able to see the ball game and see what's going on. Equity, and maybe this corresponds to the universal proportionalism, a diagram, a graphical representation of it, is where you have the right size stool so that you have the right view of the ball game. But unfortunately, all too often, reality looks like this, where the people who already have the advantage have an even better advantage, and the people who need the most are actually stuck in a ditch. So, so what we want to try to do is have this equity and the proportional universalism. So there are a lot of different ways to measure health disparities. This other monograph lists 11 different disparity measures or indices, and there are actually more than that as well. But there's a nice piece of convenient software put out by NCI that's fairly new. It's published in 2014. I think early versions of it were available a few years ago. And it will calculate those things for you if you put your data in the right way. And so I wanted to show some California data using that. So some of these data come from Dr. Pollack's study that he conducted in 1993-94. These are from the only 2 California oral health needs assessments of children to date. I think there's another one that is being planned. And what we're showing with the red line is 1993 data. This is untreated caries in elementary school children. And on the x-axis, we have the percent of school-free or reduced lunch program participation at the school level. So it's a measure of school deprivation, where this is higher SES and this is lower SES. And so you can see the gradient. And you can also see that in the second one, 2004-2005, there's a decrease in the percent or the prevalence of kids with untreated caries. The slope index of inequality in each case is shown here, negative 0.38, negative 0.23, which is basically just the slope. So maybe things were getting better, but it's hard to say. So one of the things about measuring disparities is you can measure things. As I said, there's more than 11 different indices, but some of them measure in the absolute and some of them measure in the relative. And so here's a schematic, made up data of 4 groups, A, B, C, D, and then the overall, over 4 years. And we can see they're all going down at the same rate. They're all decreasing. An absolute measure would say that there's no change between group A and group D in terms of the prevalence of the disease. It remains constant at 20%. But if we use a relative measure like an odds ratio, we see that the odds ratio goes from 2.25 all the way up to more than 3.5. And so it depends on what you're doing, but we should know what it is we're getting when we're looking at health disparity indices. And so if you plug that made-up data into the HD Calc program that NCI puts out, you find that the absolute health disparity measures are showing no change, which I think is what, in this case, for caries, we should be looking at. But the relative measures are showing an increase because the relative component is bigger. And so I question whether we really want that. Most recommendations have been to use both relative and absolute when you're reporting them. But I think probably, at least for dental disease, when we talk about very common diseases like caries and periodontal disease, that we probably are more interested in the absolute. And here's another example of this is called the relative concentration index. Again, untreated caries for the 2 different years. This dashed line is the line of reference. And it's hard to tell if things got better or didn't get better. But if we use the absolute measure, we can see that there's a change in the overall prevalence. There's a decrease. And then we can sort of see that there's a change in the area, which is what this absolute concentration index number means. And that also maybe the lowest SES groups happen to have less of the problem. And then here's another example, and this is lacking sealants for the 2 years, and you can see that for 2004-2005, this particular curve shows no gradient, which is a little peculiar, seeing no gradient, but a paper that Dr. Mejia published here shows no gradient in the percent free and reduced lunch, but does show a gradient based on language. So the percent of English language learners in a school, that there is a significant gradient using 3 different indices, whereas for income, well, free reduced price lunch, some sort of measure of the school level deprivation. There wasn't. So then finally, I'll come back to this again, and I'm going to talk about slope index of inequality. So if you remember, that's this number minus 0.3, minus 0.38, minus 0.23, and what that measure is doing. And in a paper in American Journal of Epidemiology, we found that there was a unexpected finding that we had. A reviewer asked us to do some simulation, and we found an unexpected finding, which was we looked at a sample size and changed the sample size to 1/10 and changed the sample size to 10 times the amount, and looked at the slope index of inequality based on the underlying prevalence from 0.1 to 0.9. And we would have expected that these confidence intervals would have gotten smaller as the sample size went up, as most measures, but it doesn't. And so we've recently done some work with some folks at King's College London and with Dr. Mejia at ECU to do some simulations and look at this. And so we found that it's a factor of the number of categories that you use. So if you only use 3 categories of socioeconomic position, you might have less precision than if you use 4 or 5. And so that's work that's ongoing, and we're going to be submitting a paper on that relatively soon. So last, I wanted to talk about where we are now. As Dr. Henshaw talked about, this last phase isn't really a center, so that's why I have it in quotes, of Can Do 3. We still consider ourselves a center and still consider our group's activities, things we want to interact with and give each other feedback on. But this is part of the Oral Health Disparities Consortium, or Odyssey, as I like to call it, because we're on sort of a journey, and hopefully we won't run into as many challenges as those mythical Greeks did. But I want to talk to you about our two main projects, the UH2 projects, and just give you a little snippet. So the first one is called Evaluating Standardized Preventive Care to Reduce Dental Disparities in Children. Again, a mouthful. Our short name is Willamette Disparities Evaluation. With these partners, many academic institutions, and it's headed by the co-PIs of Elizabeth Mertz and Joel White here at UCSF. So this is not, unlike some of the previous studies, this is not a randomized controlled trial, but is rather an evaluation, a multiple level evaluation of an existing program. So the Willamette Dental Group in Oregon is a very large group practice, and they're going to be evaluating the group practices, preventive-based, evidence-based, preventive focus efforts to reduce Caries burden over this time period between Medicaid and commercially insured children who are part of their practice. And they're also going to be evaluating organizational sustainability and Medicaid policy implications. And shown visually here, looking at measuring whether there's a reduction in caries over time, cost effectiveness analysis, looking at sustainability, and again, looking at the policy implications. And as Dr. Henshaw said, these are two-phased, so the early phases are going to be validating some of the measures, refining protocols, getting everything all ready to go for the final full-blown longitudinal evaluation. The other project, which is headed by myself as well as Jim Kahn here at UCSF and Francisco Ramos Gomez at UCLA, along with our colleagues here at UCSF, is a study that we call Beacon, Behavioral Economics for Oral Health Innovation. And again, going back to what has worked or what other countries have done, we looked at Mexico, we looked at some of the conditional cash transfer programs that they have had, Progresa or Oportunidades, as well as in the context of behavioral economics, where you're trying to incentivize people to do the right thing within the context of their usual behaviors. There's a fair amount of theory that supports this. I am not the theoretician, on this, so I will, if people have questions later, I will try to answer those. And our objectives are working with early Head Start families in Los Angeles County to come up with a package of incentives, a type of incentive, whether it's cash or non-cash or lottery, as well as what the frequency is and the amounts, to have them be incentivized to take care of their kids' oral health and do preventive behaviors. And the two preventive behaviors we're looking at are brushing children's teeth twice a day with fluoridated toothpaste and dental visit attendance, and with dental screenings with referral. So there are financial or financial equivalent incentives as well as non-financial incentives, and we will be evaluating those. And then finally, we also have the coordinating center for the 9 projects with our large team, which we have just staffed up completely. So we're really excited now that we have everybody on board, and we have don't have to do more job interviews and things like that, and we are moving forward with supporting the projects. So again, I want to come back to the baseball analogy for today, being the home opener. I showed you this earlier, and we have the opportunity here in San Francisco and in the other places and the other speakers to make changes that maybe don't fit exactly one of these 3 models, but is something different, to be creative, to think outside the box, just like the San Francisco Giants do with their port walk, where you can view the game for free, no matter what your height is, for 3 innings, and then they ask you to move along. So with that, we have covered a lot of ground in the last 15 years, but there's still a lot of work to do, and so we're very excited about that and moving forward, and looking forward to the question and answer session. But first, I want to thank the participants of our projects, as well as our multidisciplinary team here at UCSF, as well as our partner institutions. I know I've actually left, it's hard to believe, I think I've left out some names. I've already thought of several that I had left out, as well as our partner institutions. And in particular, I really want to thank our NIDCR partners, because as Dr. Henshaw said, during the cooperative agreement phase, they've been really instrumental, and in particular, Dr. Ruth Nojak-Raymer, who really was, I think, studied with Richard, learned a lot with Richard, would refer back to him and his things that she learned from him and while she was there, and would really help us shape our interventions and our projects. And so with that, I want to thank you all for your attention and welcome questions.
That was fantastic, and a really impressive B-roll at the end there. Then why don't we actually go ahead and do the panel session. We'll bring everybody up. Our moderator is going to be Dr. Elizabeth Mertz. We heard a little bit about her involvement in Can Do. And we'll run this session for about 25, 30 minutes. We'll see how it's going. Please line up at the mics if you have questions, and I encourage you to participate.
How are you guys doing? Does everyone need a little stretch? All right, well, first of all, I want to thank the panel. This was a fabulous day of information and sort of history and a ton of really great information. So I guess I'll start it out. So here's my question. So the theme of the day is from measurement to action, sort of global oral health disparities. And each one of you gave a wonderful story about a progression of work that you've been a part of for a very long time, whether it's Dr. Watt, the ideas of the social determinants, the social disparities and the policy issues, or the migration, or the 2 centers, but with very different focuses in terms of the way that you're doing it. So thinking about, this is a question for each one of you, thinking about where you might be, if we're thinking 10 years ahead, and we've measured and we're designing, and now we want to move to action, what's your dream? Where do you want to be in 10 years from now? What progress do you want to see?
I think you are exceptionally lucky in this country. Apart from having very talented people, you also have resources. I'm incredibly impressed, and hugely jealous of all the funding that is dedicated to disparities research. Because in other countries, like the UK, we scratch and around to get crumbs of funding, whereas you do get dedicated funding, which I think is incredibly important. So I suppose in 10 years' time, I would like to be, I think what I'd like to be in 10 years' time actually is working more closely with some of you about sharing our ideas, because I think we meet every so often at conferences and we talk about commonality, we've got some same slides, but we don't actually really begin to sort of dialogues about, well, why don't we do this and why don't we exchange this? So I suppose I would like in 10 years' time to have more effective, real collaborations internationally, apart from being retired.
Right. We'll all be doing that in retirement. Okay, Gloria?
Okay, so I'll do it from the point of migration, as was the talk, and then I want to touch on another aspect. So from migration, I would like in 10 years' time to actually see that all these policies that are being created now between countries and bilateral agreements and that they continue to progress. The disparities that we're currently seeing between the migrants and the native-born populations will actually start to reduce, and that we can find ways to better incorporate migrant populations into mainstream. But the other aspect that I would like to see in 10 years' time, it relates to teaching of the dental profession. So I think in that, find a way that we could all move forward to incorporating public health vision and action throughout the dental training, so that our dentists graduate having a wider view of what their professional role is in communities. And so I guess moving a bit from the biomedical model that we currently have now to this more public health perspective, or population health perspective.
And I will sort of pick up on that and reverse my order of things that I was going to say. I think that also we need to move health profession education forward to be more collaborative and interprofessional, because I think until that happens, we're still going to have a challenge in getting dentistry at the table. So until the other health professions understand more what we do and see us as valued colleagues, we won't be able to be at the table for those important health policy decisions. And that's where I really hope that we are in 10 years, that we have been able to take all the fabulous work that we've all done and really understanding disease and these sort of unique models, and to take it to the policy level so that we can make systems change.
And I think along the lines of that interprofessionalism, so in the fall 2015 UCSF magazine, there's an article called Poor Health, When Poverty Becomes Disease. And I would like to see us work interprofessionally with all the health professionals. I would like to see us stop being diseaseologists and to actually think about the upstream causes of causes. So the upstream, downstream still important for the people who have the disease, but if we want to really prevent disease and really improve health, we have to move upstream, and we have to start to think about causes of causes, and that starts with reorganizing institutions away from the disease towards the factor that we think is the smoking gun. Whether it's sugar, if we concentrate on sugar or tobacco or poverty or whatever the upstream cause is, oral health will improve, as will a litany of other health conditions.
The question was very interesting to me. Where would you want to be in 10 years? Well, I'm not going to be standing here in 10 years, that's for sure. So, anyway, let's wind the clock back to when I got into doing research in dental caries, 1974. That's 42 years ago. In 1980, I had a conversation with a friend and colleague of mine from the Netherlands called Ferd Driesens. And I was young and brash and said, oh, we've solved the problem of dental caries. We know the mechanism, we know how it works, we know how fluoride works. All we've got to do is do it. That was 1980, ladies and gentlemen, 36 years ago. You ask about 10 years. So what's the question for the panel? Well, we all learn something every day. I learned something a lot today from all four of you. And one of the key things that I learned was the percent of blacks who text and how many texts they do every day. That just blew me totally away. The question is, how can we capitalize on that? And how can we fulfill the dream of several of us of putting into practice what we already know? 15 years ago, the Disparities Centers were funded. Richard's jealous of that funding. Fantastic. But how far have we come in 15 years? Could we just speed that up a little bit? Because my colleague Ferd Driesens has been dead for 10 years now. So could we just speed things up? And how can we speed things up? And the last comment I'll make is, one of the things that drives me nuts in our community of dentistry and dental research is, I'll say, okay, we did a clinical trial and we showed that caries management can be done in the following way. Oh, but that was only one trial, and it was small sample numbers. We need more trials. And then we say, okay, we've got some outcomes research, we've shown a 40% reduction by doing this and that. Oh, but that's outcome study, it's not a controlled randomized clinical trial. How do we break through the barrier, ladies and gentlemen, at the panel, and get this done in 5 years instead of 10?
Well, I suppose I would respond by sharing that frustration, and I suppose what I think you're tapping into is the translation of knowledge into practice and mainstreaming it into sort of delivery systems, etc. And that is an ongoing frustration. And I suppose I didn't make it very clear, but I suppose my frustration is, and I'm as guilty as anybody, that we often keep on doing things because we get good at it, we can publish it, we get into safety, a comfortable zone, but the really difficult things are engaging with that black community who might be texting, but what are they texting about? And so I think the difficult problems are the perennial ones, and they're not quick fixes even after 15 years. But I think we've got to keep doing it, and we are making progress, and I feel quite optimistic. But it is that translation, I suppose, is the key.
I can't add much more to that. I see the value now about engaging with communities and working with the communities, and really see how, yes, we do need a whole bunch of studies in this one and this one and this one and this one, but I guess part of that I attribute to the diversity of our populations and such. So really it comes down to with the groups that we're working with. And as I learn more about working with communities, I can see how those local actions really do have an impact globally. Yeah.
I think the only thing that I have to add, because I agree with both of you, is that I think that we in oral health research are still fighting sometimes an uphill battle with the value of oral health as perceived by the general public, especially vulnerable populations, and especially when you're dealing with young kids. Those are only baby teeth, they're gonna fall out. There's still a lot of work to be done. I think, and it is a very complex problem. And so I think until we can overcome that issue, it's gonna still be a challenge.
So I think the translation from sort of clinical trial to practice, people used to say it's 20 years in terms of a drug or a device. So it is a little bit shorter. I think it's down to maybe 10, for example, the fluoride varnish as one example. But it's still not fast enough. We still need to do more. And I think that engaging with populations who are in the ways they already communicate. So the text example, coming back to the text example. When we talk about global health, a lot of countries have jumped and not developed a telecommunications infrastructure, and they've just not done that, and instead now they have mobile communications infrastructure. So there may be a lot of other kinds of technologies where similar leaps can be made over what we thought of as the progression, and that those sorts of things will really be big breakthroughs in terms of providing, in that case, communication to people, but maybe there's some way to provide health to people in terms of global communities as well in that regard.
Mm-hmm.
So a couple of things with immigrant oral health. 30 odd years ago, I was involved in looking at the kids in California, in San Francisco specifically, and we found that we just looked at the kids' teeth in these particular schools every 3 months. I went in there and examined the kids, and we didn't have any intervention at all. When we analyzed the data after 2 years, found that those that came from countries who had specific kind of political problems with regard to the United States, whereby if they came from a particular country, they may have been given refugee status. Now, refugee status confers a lot of benefits. You get Medicaid for 18 months, including dental benefits. You get help from the Catholic agencies to get a job for the parents, to retain the job, to if you have to take time off from your work, to take your kid to the dentist for those multiple appointments without fear of losing the job. Whereas those that came without refugee status struggled, and the oral health of the kids on refugee status certainly improved. Whereas the kids from non-refugee status, their dental health did not improve. So I think what we do for immigrants, and this is becoming a worldwide problem now with Syria and other countries, we need to consider what works for people, and are we willing to pay for these services. On the issue of immigrant child health, the American Academy of Pediatrics has recently put together a toolkit called Immigrant Child Health Toolkit, which is available online. And we certainly need to work with our pediatric colleagues. And then finally, just a comment about the study that I did so many years ago that Dr. Gansky referenced. I think you really need 3 data points, and you said we only have 2 studies.
The U.S. National Oral Health Surveillance System doesn't consider one of those 2 as being representative enough.
Right, so there's different methodology in those studies. We didn't use the same methodology, and there were certain new technologies. For instance, the dental Medicaid program in California did not include sealants prior to the survey that I did 20 years ago. And so it could well be that sealants made a difference, but we don't really know what made a difference over that 20-year period either. So those are just comments, and I just thank the panel again for the presentations.
Well, I appreciate your comments, and I think part of the importance with that is about these binational policies, for example. So introducing immigrants to the healthcare system, and the recommendation is actually that regardless of their immigration status, but that is something that each country has to consider based on their own economies and what they're able to provide and what they're able to do. But I see that there's certainly a movement towards, in some countries, to try and incorporate migrants into the healthcare system somehow. Much more needs to be done, but now with so many international migration going on, I'm sure that that's going to start triggering more conversations, and hopefully when we'd be able to move faster on that.
And California does have data on refugees, health data on refugees in California at the UCSF Health Disparities Symposium about a year and a half ago, there was a student from Stanford who presented a poster. It didn't have the oral health data, but it had other health data. So if anyone is interested in that issue, in refugee health, that there's some data sets out there that I don't think have been analyzed for oral health.
Just an observation that in Europe, because you mentioned Syria, that in European countries, the sort of tension is in some of the sort of xenophobic politicians talk about health services being swamped by migrants. So that's an argument used to sort of put the barriers up. But then in Germany, for example, I think there's real issues about how to accommodate 1 million people that have arrived, more or less. It is, in some parts of Europe, such a big issue at the moment. Mm-hmm. It really, it's a big, big problem.
Yeah, it is.
So as a recovering oral pathologist, I'm still slightly addicted to mechanism, biology. And as I look at the wonderful social gradient construct that you show us, Richard, and the Fisher-Owens, Caries thing, I still want to know what's going on with the teeth. What is it about the social gradient? What is it about all of those multifactorial determinants of childhood caries, for example, and of other oral diseases? Where do they hit the tissue and the pathogenesis of the disease? Is it with caries something as simple as sugar? Just as Marmot postulated with the civil servant gradient, that it was stress. There's got to be something going on. We can't just go on talking about these broader contexts and ignore the events in the mouth, at the tissue. Thank you.
Well, I just one observation, because at UCL, I'm on the 3rd floor, and my office is directly opposite a laboratory where they do stress testing. So there's a psychobiology group within our department which looks at the biology and the inflammation. It looks very much at the biological processes and tries to link that all the way back to the social gradient. So I think it's incredibly important we put it all together. And I suppose one of the criticisms is that whether it's the Fisher-Owens model or the other determinants model, that we're overcomplicating things, because ultimately it's a disease process that's happening.
That's what I'm trying to get at.
Well, I suppose my understanding, having come from a dental background, I think one of the ways in for us is that we are very strong biologically in terms of our training, and it's trying to really understand the disease process within that broader context. So I think that's where one thing we can really help, because a lot of the other public health people can't do that. But in answer to your question about early childhood caries, I don't think we know why, because we still try all these different interventions, and it's still unclear why a disease process should discriminate effect among some groups but not others. So I think we just don't know, unless in Boston or San Francisco.
Well, there's some work that you probably know about here, Tom Boyce and Pam Dembeston, that shows a relationship between maternal stress and enamel thickness of the children's teeth. So there are ways where stress does, as Nancy Adler and others say, get under the skin and create something biologically, mechanistically. I'm sure that's not the only component, though. There it is definitely multifactorial, and part of me, though, says, we know some things that are very bad for people, and if we can intervene in a way that works with their culture, that they're going to actually embrace it, that we can improve a lot of health conditions, including oral health conditions. But it doesn't mean that we shouldn't study the mechanisms.
I suppose one thing we have started doing is a more salutogenic approach, that looking at populations where everything is stacked against them, but some people remain to be healthy, is understanding what the protective sort of mechanisms are. I don't know if you're doing stuff like that in the US, but to try and work out how resilience and people's ability to cope with what is adverse. But so that's another sort of other way of looking at it.
Yeah, I think that was the approach that the University of Michigan Health Disparities Center took, because all of their work was focused on a couple dozen of the poorest census blocks in Detroit.
I'd like to thank the panel, and hopefully my comments will flow on with the discussions and questions we've had previously. We've had some historical views, we've had some biological views. Moving on to modern techniques like texting or e-health, and Gloria's comment about wanting to make dental students aware of public dental health. I'd like to say that might actually help with the workforce issues that we're having. I mean, I don't know about States or the UK, but in Australia, the dentists, graduating dentists, do not get work in the cities, but they work with rural areas and within the challenges that we now face in special needs dentistry, who deals with vulnerable populations. So if we start teaching them, not just going multi-sectorial to other areas, which I do agree, I think if we incorporate in that sort of research in that areas, incorporating clinicians in research, that might actually work well. And to Helen's talk, as I said, I really enjoyed your talk as well. You're mentioning about texting, but my suggestion, or my question rather, is if we are to include non-dental professionals in the screening process, I have no problems with, but why not include allied dental health, like what we have in Australia is dental therapists? Why not use them? Because there's, I would say, underutilization of allied dental health professionals who are actually trained in oral health promotion and education and prevention. So that might be a lot more cost effective in the long run, because we have had training with GPs and nurses in the aged care sector, and I think it works well because they learn, but once the funding or once the program is seized, then that falls off as well, when we can't continue to train them.
Yeah, I think that the model is going to be very different based on the community that it's implemented in. So where that particular project is in rural India, and so they really don't have those type of workers. But yeah, it would have to be adapted to be the most effective and efficient and cost effective based on the local resources.
I just have a quick question. Dr. Watt, you showed a slide that was intriguing to me. It was the burden of oral disease on the global map, and it used the DALI. And I thought, the DALI, it's so broadly applicable in so many circumstances. And my question then is, why don't we see use of the DALI more? Is there appropriate uses when we're talking about global burden of disease and measurement and oral health implications for the DALI?
Okay, well, I think one thing you learn when you sort of keep working is I knew next to nothing about DALIs. I just used that slide because someone gave it to me. So I've been rumbled because I know nothing. But I think what I do know enough about is I think that sometimes the difficulty is our conditions aren't measurable with some of the more generic measures, which is a problem because then we haven't got direct comparability with other conditions. And I have to say, and I've tried to ask so many times with the global burden of disease study, although the figures for oral diseases come out so high, it's not very transparent how we get those figures. And if you ask some of the investigators, unless I'm being stupid, I don't really understand the mechanisms and metrics that get where we are. But so I'm afraid I can't answer the question about DALIs because I know nothing about them. But I suppose just demonstrating the impact of our conditions, I think now we have an increasing amount of data that is quite meaningful and people can relate to. I don't know if you know about DALIs, do you? I'm sure you do.
I think Ben knows more, but yeah, so disease-adjusted life years or quality-adjusted life years, DALIs or QALYs, and I think typically what happens with oral health conditions is they're highly prevalent, but people rate them as the impact on people's lives, because usually it's mortality, as being pretty small. So usually those numbers for oral health conditions come out to be fairly small, even though the prevalence is very high. So it's it's not maybe as useful a measure for us. I don't know if others have other comments about that, but when I'm not a health economist, and we have 3 on our team. It's always important to have an odd number of health economists in case it comes to a vote. And that's when I mention, should we be using DALYs or QALYs, they say, well, you might as well just use prevalence, because if you're comparing within your disease state.
Well, and in the new study that we have, the My UH2 study, we're actually measuring health utility in the children, and we're going to see if we can translate. Part of the feasibility analysis is to translate that into a quality adjusted life year to see if we can quantify in our cost benefit analysis some way. But we haven't done it yet, so I just can tell you we figured out how to do it, but we have to collect the data from our population and get there. So stay tuned. Like in 5 years, we'll know. Yeah, sorry. All right. No other questions. So thank you so much for coming today. Really appreciate your attendance. And do you have any final words, Ben, you want to wrap us up with?
Yeah, so thank you very much, Beth. Just a tremendous amount of information that we learned today. Really lots of reasons for optimism in terms of the models that were demonstrated, what we know is effective, what we can do, what we can look to do in the future. Also a lot of reasons to be humbled, particularly thinking about, we heard just the lack of efficiency and questionable effectiveness of downstream individual focused interventions, and yet what a large amount of our effort and energy is placed in those approaches. And just what a long ways we have to go from the standpoint of education and policy and reorienting how we think about oral diseases. A couple more orders of business before we let you go. Some people that absolutely need to be thanked today. Everybody who's part of our Global Oral Health Steering Committee. Putting together today's events was a year-long process, and it's going to start. The 7th annual symposium starts planning tomorrow. So everyone who was part of that, putting this event together, thinking about whom to invite, what our theme would be, thank you to all of them. Terry Sonoda and Roger Miraz are absolutely tremendous, indispensable to making this happen. All of our volunteers that helped with running the microphones, keeping the AV equipment going, taking photographs, making sure folks didn't get lost, although I'm sure maybe a few did get lost somewhere along the way, but we got most of them. So thank you so much for your effort. Big hand to all of them and our volunteers today. Thank you to the partnership and our collaboration with the Philip R. Lee Institute for Health Policy Studies. They helped get this event recorded so that it can disseminate and live on and continue to influence and entertain. And absolutely, we could not be here. We would not have a program in global oral health if it wasn't for the leadership and the vision of 2 very important people, Dr. John Greenspan and Dr. John Featherstone, have been such tremendous supporters of this program of oral health, what our school can do to make a difference, and their support has been unwavering from the very beginning. So a huge hand to them. And finally, you saw it in your program, but we have a couple of special points of recognition. We have our Student of the Year and Faculty of the Year when it comes to global oral health. I'm going to call them both up here. This is almost a lifetime achievement when you think about the amount of time both of these individuals have put in here. Oscar Reyna is one of our graduating dental students. He is now a 4th year, heading on to orthodontics residency at Harvard School of Dental Medicine. He started with the Global Oral Health Project as a first-year student and has continued to ask important questions, analyze his data, disseminate the results. And Ling Zan has been such a tremendous ambassador of the School of Dentistry when it comes to reaching out to the greater campus and global health sciences and creating a presence that was integral in our Roatan, Honduras project. She's been a mentor for numerous students, residents, and done really good science and really good work. So congratulations to both of them. If you could come on up, we have some certificates for you.